Those of you that have joined, please put your name, agency affiliation, and title in the chat for us. Be great to know all of the folks that we have here across all the practice for post-permanency, adoptions, guardianship. Looks like we're ready to get started. I'm going to turn it over to our Assistant Branch Chief in the Adoption Services Bureau for CDSS, Julie Pickens. Good morning, Julie.
Good morning, Rebecca. Can you hear me? Can you give me a thumbs up if you could hear me?
We can hear you. Thank you.
Perfect. Apologies. I'm madly dashing from one meeting to another this morning. So want to just say a quick welcome to folks. Glad you are all here this Friday morning to join in this training brought to you in collaboration between CDSS, the Child and Family Policy Institute of California, and the Child Welfare Directors Association. We are pleased to offer this important resource for adopted and guardianship families to help access and meet the needs of their children and youth. We invite you to share the information you learned today with the families you serve, whether as they prepare for finalization or they're already in post-permanency. All youth who have exited foster care to permanency are eligible for Medi-Cal and have been identified as categorically eligible for these services when enrolled in a managed care plan. We hope that you take away information today that can then help you as you help families and children, and also connect you with folks who can assist moving forward. With that, I will turn it back over to Rebecca.
And thank you. And I will pass the baton to our presenters today. Thank you, Julie.
Thank you. Good morning, everyone. My name is Beljeet Handel, and I'm a CFPIC CalAIM consultant. Prior to being a consultant with CFPIC, I was working with Mariposa County, and prior to that, Merced County. I've been in the CalAIM space now for about 4 to 5 years, helping county programs, child welfare, adult and aging, IHSS really understand the opportunities here and the benefits for children, youth, families, and adults. So today we're really going to give you a robust overview of CalAIM and how it applies to the work that you're doing. I'm going to hand it over to my colleague, Locke.
Good morning, everybody. My name is Locke Wang. I'm a child welfare policy consultant with the County Welfare Directors Association. I've been working with vulnerable populations for a while now. And I was actually the child welfare director in San Mateo County for more than 5 years. That's where San Francisco Airport is. And relevant to the conversation today, I actually spent about 7 years as a adoptions line worker and supervisor in the LA County Department of Children and Family Services.
Great, thank you. So just some housekeeping items. We are going to take a break at the halfway point, which is typically after we've completed section 5 of the agenda here on community supports, and we'll take a 15-minute break. I'm a big fan of taking breaks and self-care, and so we're going to make sure we do that for you guys today. We're together till 12 o'clock, so we are going to try and leave time at the end for questions and answers. And if any point during our presentation today a question comes up, please go ahead and put it in the chat. Sometimes we're able to answer your question in the chat, or we may lift it up as we're going through the training, or wait until the end to answer it then. But one of the things that I really want to lift up today is it's really good for us to hear what's going on with children, youth, and families, and to better understand if you have made referrals to ECM or community supports, or there's unique issues that you're questioning how this would apply. Please ask those questions, because they allow us to get more into details around how these benefits could really help the individuals that you're working with. So this is the agenda for today. We have put the slide deck in the chat. Don't get scared away from the number of slides. We did this presentation yesterday and we actually got done 30 minutes before the end of the training. And so that allowed us to have a robust conversation after the presentation. There are a lot of acronyms that are thrown out. And so this slide is just to give some of those acronyms. So you can always refer back to this slide if we say something that you don't know what it is. So I like to always start any CalAIM training with this visual, and the visual is, as you see it in the middle, is the child, the youth, and the family. They are why we are here today. They are the focus for CalAIM as well. And around them, you see all the systems that they may be trying to coordinate with to meet the needs of the child and youth. And this could include behavioral health, education, juvenile justice, child welfare, healthcare providers, community-based organizations, the managed care plans, and public assistance. So we've got all these systems, each with their own rules, funding, and own jargon. Historically, these systems have not talked to each other very well. And so youth on your caseload may be trying to navigate multiple systems. And so CalAIM is really trying to attempt to reduce fragmentation that may exist in our systems and really forcing us to put the child at the center and asking systems to really coordinate around the child, with the child and family. And this is something that we have been working on in child welfare through our AB 2083 work and the System of Care framework. And so CalAIM really folds in nicely to that work that we've already been doing. So let's start with the basics. What is CalAIM and why does it matter? So CalAIM is an acronym and it stands for California Advancing and Innovating Medi-Cal. The simplest way to describe it, it's a multi-year effort to change the way healthcare gets delivered inside California's Medicaid program, which we call Medi-Cal here in California. So the goal is not subtle. California is trying to build a Medi-Cal system that is more coordinated, more person-centered, and more equitable than the one we've had for the last several decades. The 4 bullets on this slide are the official goals. California is looking to address its members' physical and mental health needs together, not in separate silos. It's looking to improve and integrate care. It's looking to use this initiative as a catalyst for equity and justice, recognizing that we still have populations with health disparities, and collectively work together to build a healthier state. So there are 3 reasons why CalAIM matters, especially for the work that you do. First, CalAIM opens new revenue systems. It brings federal Medicaid dollars to services that previously were not reimbursable, that extends what counties and community-based organizations can actually afford to offer the families and children and youth on your caseload. Second, it's new benefits and services for vulnerable populations. And we're going to spend majority of the time talking about the 2 biggest ones, which is enhanced care management, which you may have heard referenced to as ECM, and community supports. And then third, and this is important, again, kind of lifting up that circle visual slide that I had prior. It's an opportunity to break down silos. So CalAIM gives us tools to coordinate around that reality, and whether we use tools well is up to us. So really kind of helping drive the coordination more through these benefits. So now I'm going to turn it over to Locke to further explain the why as it relates to child welfare.
So Medi-Cal managed care plans have been around since the 1970s. And if they had already existed, why did DHCS pull together experts and stakeholders a few years ago to try to reimagine what Medi-Cal might look like? You know, what was the fuss about? So they found in working with Medi-Cal managed care a number of issues. The first insight was that people in the population have different health needs. So a lot of people might have low health needs or no health issues at all, while others may have high health needs. And you can begin to categorize these health needs by certain levels. So at the sort of foundation, about 80% of beneficiaries have low health needs. In essence, they were pretty much healthy all of the time. About 15% of the beneficiaries have moderate to high health needs, which might require early intervention. So, for example, they might have asthma or type 2 diabetes. Very manageable, but still a higher level of health needs. And then about 5% of beneficiaries had very high risks. They might have cancer, they might have type 1 diabetes, they might have a severe mental health diagnosis. The 5% of this population led to, in essence, about 50% of the resources, more than 50% of the resources and costs with a particular this population and whatnot. So one example are youth in foster care, in which they represent about 4% of the entire child population on Medicaid, Medi-Cal, yet they account for more than half of the psychological visits, almost half of the psychiatry visits, more than 4 in 10 of all inpatient public hospital visits, and more than a quarter of all psychiatric inpatient hospitalizations. So the third insight is that these determinants of health, especially those who were in the very high risk categories, were actually not biological. It wasn't due to a bug or a virus or a bacteria. It was actually due to something called social determinants of health. In essence, these are the conditions in which people are born, grow, live, work, and age, which can actually affect their health. So job loss, food insecurity, housing instability, homelessness leads to increased adverse physical and mental health issues, especially in children. Being uninsured leads to poor health and actually increases the chance of a premature death by about 25%. And this was partly due to the fact that people waited as long as possible to get healthcare because healthcare was very expensive. And unfortunately, for some, they waited too long. Of the ACEs questions, the adverse childhood experiences questions, about 6 in 10 are actually related to abuse or neglect as children. And research has shown severe adverse health effects at a score of or equal to greater than 4 or more ACEs. So people are 2.4 times as likely to get cancer than those with no ACEs. They're 3 times as likely to get diabetes. They're more than 3 times as likely to get heart disease and respiratory diseases, and nearly 6 times as likely to get a stroke. And those with at least 4 ACEs die an average of 15 years younger than those without ACEs. And if you have a score of 6 or more, you're likely to die an average of 20 years earlier. And one of the most striking statistics to me is that if you don't have ACEs, but there's a family member who does, you're twice as likely to die prematurely. So the fourth insight was that while doctors, nurses, and other healthcare professionals are an important part of addressing social determinants of health, most of the resources that address these social determinants of health actually have to come from the community where a person lives. So this includes not only human services agencies, but also community-based nonprofit organizations and other non-healthcare providers. So a benefits analyst in a human services agency will reduce the likelihood of an early death for 1 out of 4 people when they sign them up for health insurance. Child welfare and probation staff lessen the likelihood of ACE scores increasing when they are working with youth and their families. And nonprofit agencies and other community partners reduce these outcomes by helping people secure food, jobs, and even get them housing. So the fifth insight was that you can manage the care for the categories of benefits. For the 80% who have low health needs, you have population health management. For the 15% who have moderate or high health needs, you have complex care management. And for about the 5% who have very high healthcare needs, you have enhanced care management, usually non-healthcare providers in the community. Now, the sixth insight was that for population health management, the infrastructure for population health management was already in place. You had to tweak it a little bit, but it was already there. Complex care management, the infrastructure was also already in place. You might have to tweak it a little bit more. However, for enhanced care management, the structure had not been built yet, so we had to build that capacity. How did California help to build this capacity? They invested $1.5 billion over 2.5 years to build out both enhanced care management and community supports. And they've created policy manuals for both.
All right, so now one of the things that we feel that we need to do first before we actually get into the benefits on CalAIM is that you need to understand the system they live inside, which is Medi-Cal, and in particular, Medi-Cal managed care. So just a quick refresher here. Medi-Cal is California's Medicaid program, and this is the public health insurance for people qualifying based on income and other factors. So there's three things that we mentioned on this slide. First, the financing. Medi-Cal is paid for jointly by the state and federal government. Eligibility. Medi-Cal covers low-income families and children, seniors, persons with disabilities, foster youth, pregnant individuals, and people with particular qualifying conditions. So almost every population you touch as adoption staff, either pre-adoption or post-adoption, has been Medi-Cal eligible. And the number to remember, enrollment currently hovers around 15 million folks in California on Medi-Cal. Of these 15 million, roughly 97% are receiving their Medi-Cal through a managed care plan. Now, there is still a subset that is receiving their Medi-Cal through a fee-for-service, and we're going to talk about that in a moment. And then there also is a subset that is on share of cost Medi-Cal. It's important as we continue on with the training today to understand that the benefits that are part of CalAIM are only offered through managed care Medi-Cal. They are not available if the child or youth or the individual is on fee-for-service or they have a share of cost Medi-Cal. So there are two models, fee-for-service, or what I used to call straight Medi-Cal, and then managed care plan, which the acronym is MCP. So a good way to think of fee-for-service is like a PPO if you have PPO as part of your private health insurance. This is where the state pays providers directly for each service that gets delivered. There is no defined network, and the Medi-Cal member can go to anyone who accepts Medi-Cal. Now, this sounds flexible, but the downside is there is no one accountable for coordinating the care, and over time, fewer providers have been willing to accept the fee-for-service rates. Now, the second model is the managed care model, and this is where the state contracts with the managed care plan and pays that plan a flat rate per member per month, and this is called a capitated PMPM payment. This covers all the contracted services that the plan has to provide to their Medi-Cal members. The managed care plan then builds a network of providers and pays those providers directly. The managed care plan is on the hook for coordinating care, for network adequacy, for outcomes, and several other things that we're actually going to highlight in a couple of slides with a table comparison. The shift to managed care is what made CalAIM possible. because now you have one entity that's accountable for the whole picture, and you require that entity to do things like enhanced care management, which is again not available if a member has fee-for-service or share of cost Medi-Cal. So there are two kinds of managed care plans operating in California. On the left, we have the commercial health plans that you probably recognize, such as Anthem, Blue Shield of California, Health Net, Kaiser, and Molina. These are not only offered in California, they're also national insurers. On the right, the local plans, and these are uniquely Californian. There are 17 local plans across the state, and together they serve more than 70% of the Medi-Cal managed care enrollees statewide. So local plans are present in 51 of 58 counties. It's important to mention that, and we're going to get into this later, that sometimes youth move from county to county, and when this happens, their plan in one county may not be available in the next county over. And so we're going to talk about some of the protections that are in place for members who were receiving specialized care or benefits in one county and how those go over with them in the next county with the next plan. It's important to know on that slide also we put, if you don't know which plan is being offered in your county, we do have a link on the slide that you can look that up. Kaiser of the commercial plans is offered in 32 of the 58 counties. And then a large local plan, Partnership Health Plan, is offered in 24 of the 58 counties. Again, sometimes the plan that a youth had in one county is not offered in the next county. And so coordination really becomes critical here, especially if they're receiving specialized services and supports. So this is that table that I was talking about before. Public Works Alliance created information to kind of inform this table here. And it really helps you to kind of make a comparison of what you get when you're on fee-for-service versus what you receive when you're in a managed care plan. It's important to know that you definitely get, like I've already mentioned, a lot of additional services if you're part of a managed care plan versus fee-for-service. And there is a lot of conversation that's happening across the state in child welfare departments about shifting fee-for-service foster youth over to managed care plan. And again, can't stress this enough, in order to take advantage of the benefits under CalAIM, the foster youth or the adopted and guardianship child or youth has to be enrolled in a Medi-Cal managed care plan. So CalAIM has many initiatives. It actually has 11 total initiatives embedded in it. And today we are going to highlight the two that apply to the work that you're doing. And we're looking for you to make referrals for these two initiatives. So the first is Enhanced Care Management, commonly known as ECM or Community Supports. Now this slide shares the structure of the administration of ECM and community supports. And so CalAIM is driven by the Department of Healthcare Services, who drives policy, oversight. Then the responsibility of implementation at the local level is done by the managed care plan. And a big part of the responsibility for the plans is that in every county they have a presence, they have to stand up an ECM providers and community support providers. And so this work is typically done by contracting. The managed care plans contract with local community-based organizations who have experience and expertise in working with particular populations of focus that we're going to mention later, and then also in providing the services and supports as part of the community supports options, and we're going to go into those later as well. Just give me 1 second. For some reason, my PowerPoint turned off, so I need to bring my PowerPoint back up and my notes. But we are going to move into the care management continuum, and understanding this is crucial. This helps you understand, again, what is provided to folks in a Medi-Cal managed care plan. And this is not something that is part of Medi-Cal when you're receiving it through fee-for-service or share of cost. Sorry, 1 second. I don't know why my PowerPoint turned off. I'm just going to get through these slides. Okay. So this slide shows the full care management continuum under the Medi-Cal managed care requirements and part of their contract with the state. So think of it as a pyramid. At the base is basic population health management. These are the foundational services that all managed care plan members receive regardless of risk level. In the middle is complex care management for members at higher and medium rising risk who need coordination but maybe don't meet ECM criteria. And at the top is enhanced care management. This is the most intensive level for the highest need members. And then off to the side here, we have transitional care services, and these cut across all levels, supporting members transferring between care settings. And Locke is going to go into this a little bit more in a couple of slides. But one thing to think about is the plans in meeting the care management continuum. As new members become enrolled in a plan, they are first going through a process of screening what they know about the member, what aid codes did they receive from DHCS that identifies them either as being quickly identified as being a foster youth. So foster care aid codes are provided to the plans for each member that has those aid codes. And so from that, they do a risk stratification or risk assessment, and that's where risk is assigned. And so everyone is at the low first, and then as they understand the member more, they could go to medium, high, or very high. And ECM, again, is really looking to target the very high members on managed care plan Medi-Cal and providing those services. So, but let's go through each of these levels first in a little bit more detail. So again, basic population health management, it's the service that is provided to everyone, and what you get in this is access to primary care, care coordination, navigation and referrals, information sharing between providers, wellness and prevention programs. And this is for folks who, typically are seen as being healthy and just need their routine checkups. Then we have complex care management, which is the middle tier. It's designed for members at higher and medium rising risk, people who maybe need a little bit more for care coordination, but not at more intense levels. And Locke is going to share more about what CCM is and how it works in the care continuum system. And then we have transitional care services, which is open to all members on a managed care plan. And these support members moving between settings, and this includes hospital discharges, facility transitions, and this also includes behavioral health facilities as well. So I'm going to hand it back over to Locke to explain this further.
So managed care plans are really expected to use a consistent assessment process and assessment tools to identify members who are likely to suffer adverse health consequences upon discharge without adequate discharge planning. So as Baljeet said, this is available to all members, all beneficiaries, not just those who are in foster care or in one of the other aspects. For those who have been on the technical assistance calls, one of the things that we talk about is Health and Safety Code 1262.5, which requires a hospital discharge plan evaluation, which is one step higher than a hospital discharge plan to determine the potential benefits for that beneficiary and whatnot. So Medi-Cal managed care plans have to know in a timely manner each member's admission, discharge, and transfer. And the old sort of approach was only into hospitals, and the newer thinking is into things that include residential or treatment facilities like the SRTPs and the 2 community treatment facilities, and even incarceration facilities like juvenile hall, right? So it doesn't mean that it for juvenile hall, it's not the law enforcement side, it is the health piece of it. So the managed care plans must ensure that beneficiaries are offered direct services of a care manager. So whoever does not already have a care manager through ECM or CCM, the managed care plan can use their own staff to accomplish this or contract with a hospital to identify somebody who can serve as the TCS care manager. The managed care plans must notify the identified responsible care manager of the assignment of the member's admissions status. So when they are notified from a hospital, the managed care plan is told by a hospital, hey, one of your beneficiaries is here in our hospital, they're supposed to start that process to make sure that there is a TCS care manager assigned. They must also notify the assignment and of the member wherever they are, and they have to ensure that the member has contact information for the TCS care manager and for members who are actually admitted into an acute psychiatric hospital or other types of similar facilities, etc. They know that the mental health plans are responsible for the primary coordination of this, but they also recognize that these mental health plans have very limited access and ability to coordinate across all the different systems, and certainly to even address physical health care needs. So as such, the managed care plans are supposed to, again, assign and contract with a TCS care manager to help coordinate with the behavioral health or county care coordinators when they are in an STRTP, et cetera.
So we want to lift up 2 positions that were created and mandated on the managed care plans as being part of their staffing. So the first one is the child welfare liaison, and this is a managed care plan requirement to have this position as of January 1st, 2024. We have the APL cited there on the slide. So the primary purpose of this position is to ensure the healthcare needs of children and youth in foster care and AAP are met. They serve as the point of contact to resolve escalated access and coordination issues, and they support both care managers on the ECM side as well as child welfare staff and leadership. Their responsibilities include acting as a resource for ECM lead care managers and child welfare staff, resolving barriers to accessing MCP services and referrals, facilitating enrollment and disenrollment when members move between counties. So again, if your individual is moving from one county to another, it's important to start having conversations with this liaison, especially if the plan is going to be offered in the next county. And if the plan is not going to be offered, how can they assist with continuity of care, which we're going to talk about later. The second position that the plans must offer is, or not offer, must have on their staffing is the MCP tribal liaison. And this person is really working with our Native American members. And so we wanted to lift this up because recognizing that many of you are also working with children that have the ICWA designation, or you're working with somebody who has Native American heritage, that this is another person that could assist you in working with this unique population in child welfare. So in enhanced care management, now we're going to get to this benefit. This is where CalAIM really differentiates itself from what came before. So enhanced care management is a whole person interdisciplinary approach to care that addresses the clinical and non-clinical needs of members with the most complex medical and social needs. One of the things that I really appreciate about what the state did with CalAIM is that they said, we know that 3 to 5% of our Medi-Cal population is the highest need, most vulnerable, and they need more. And so this is what ECM is really trying to target, that percentage of the Medi-Cal population. ECM provides systematic coordination of services and comprehensive care management that is community-based, interdisciplinary, high-touch, and person-centered. ECM is a statewide Medi-Cal benefit. This is a mandatory benefit that the plans have to offer in all the counties that they have a presence. And we do cite the ECM policy guide there on the slide. And so it's a great resource to read. So there are 5 critical things that ECM is looking to do. One is to break down traditional walls of healthcare, go beyond just hospitals and clinical settings, and into the communities where members live. Again, it's looking to provide high-need members with in-person care management where they live. It's looking to introduce a better way to coordinate care across all the providers and systems involved in a person's life. It gives a member access to a single lead care manager, one person who provides comprehensive care management and coordinates all of the member's health and health-related care and services. And lastly, it makes connections to the quality care members need, no matter where they seek it. So in plain language, ECM is a single accountable person walking alongside a high-need member, helping them navigate everything. So for children and youth that you work with who have complex needs, and what we know is that it's multiple complex needs, this is potentially somebody that could work alongside you as you try and meet the needs of these children and youth. So there are 7 core services of ECM. One thing to mention here is that the referrals land better when they come from someone that knows the member. And that's why we're really pushing for you to make these referrals if they're appropriate. Now, the plans know already who could qualify or who qualifies for ECM because they have aid codes. But what we have found is when plans or their ECM providers do cold calls, they don't, the percentage that actually agree to the services is very, very low. And so the state wants the referrals to come organically from the member themselves, from their family members, from professionals that are working with them, or from systems that are interacting with them. So it could come from hospitals as part of the discharge plan. They could come from their healthcare providers. They could come from the behavioral health department. And then again, they could come from you as well. So when you make a referral, the first core service that an ECM lead care manager has to do is do the outreach and engagement to make sure that the member actually understands the benefit and what they are signing up for. And when they agree to this service, the authorization that is received allows the ECM lead care manager to work with them for 1 year. And then after that, reauthorizations are requested. And some plans, it's every 6 months that you ask for a reauthorization, and some plans, it might be another year. It just depends plan by plan. Then they move on to assessment and care planning, which Locke is going to get into in more detail, and the coordination of care. They offer a health promotion as well. They do transitional care services. They work with the member and family, and then they make referrals to additional services that are available in the community, but also that are part of the slew of benefits and services that the managed care plan offers, which includes the community supports that have been part of the CalAIM package. And we're going to talk about those later, but those are 15 community supports. And so one of the things that I really like to lift up here is you can make one referral to ECM, and then the ECM lead care manager takes care of all the additional referrals that need to be made, or you could make referrals to community supports, and those could be 15 separate referrals that you have to make. So really pushing for folks to, if appropriate, and you see that this would benefit the person you're working with, to make the ECM referral first. So I'm going to hand it over to Locke.
So per timely access standards, once a beneficiary has been deemed eligible for ECM, that managed care plan has 10 business days to refer them to an ECM provider in the community. And unless the ECM provider doesn't have capacity, that ECM provider will immediately accept the beneficiary and assign them an ECM lead care manager. And then the ECM lead care manager is responsible for the coordination of the beneficiary's enhanced care management, as well as other community supports through the development of the ECM care management plan. Now, there's redundancy in the system. For example, if the beneficiary doesn't have a primary care provider, the ECM lead care manager assures that the beneficiary will then be assigned a primary care provider. Further, if they need transitional care services, the ECM lead care manager will become that beneficiary's TCS care manager. There are no network adequacy issues. This essentially means that under the old model, you'd have to go to the office or to try to meet with the ECM lead care manager. But under this new model, the ECM care manager will go to wherever the beneficiary is. If they are homeless, they'll go into the community and find that person. If they're currently in the hospital, they'll go to the hospital and work with the parents and so on. So this is really important that this ECM care management plan is a comprehensive, individualized, person-centered care plan developed for the beneficiary, by the beneficiary, and if it's someone under 18, by their parents. And this care plan incorporates the desires of the beneficiary and addresses their needs in the full spectrum of the different services and whatnot. The ECM care management plan not only has to identify what services are already in place, but it also has to identify the goals as well as what is to be monitored, identify service and service providers, and then identify timeframes of when to follow up with the beneficiary and when they are making appointments with those particular providers. And to me, one of the most important but often missed nuances is that a copy of this care management plan has to be given to the beneficiary and, if applicable, to their parents or whoever has care, custody, and control. So a beneficiary, and we talked about this continuum of care where you have complex care management for the 15% and enhanced care management for the 5%. They cannot be enrolled in both CCM and ECM at the same time. CCM is actually considered part of the ECM continuum of care for that management. So the Department of Healthcare Services really encourages managed care plans to work with providers to contract for care management continuum of both ECM as well as CCM. Baljeet had mentioned earlier some of these, and we're going to go into a little bit more detail. But you can see some of the populations of focus, there are 9 of them. Some of them focus only on adults, some of them focus only on children, and the majority actually have components for both adults and for children.
Yeah, so ECM is not for everyone on Medi-Cal. It's targeted to receive ECM. A member has to meet the criteria for one of the populations of focus. We're gonna go through each of these populations for the child and youth. There are 2 that are only for adults, so we're not going to cover those today because they're typically for folks that are in nursing facilities, or we're trying to make sure that they don't end up in a nursing facility, so we're not covering those. But as we go through these slides on the populations of focus, bear in mind that your individual may qualify under more than one population of focus, and that's okay. When you make the referral, you want to check every single population of focus that you think they qualify under. Because remember in that slide where we talk about the administration and oversight of CalAIM, the plans are responsible for finding ECM providers who meet certain expectations that the state have of who could work with children and youth in the homeless population of focus and who can work with children and youth in the child welfare population of focus. And it's on the plans to vet the providers who are looking to come on as contracted providers to make sure that we are actually contracting with the right people for the right agencies for the right populations, so that you don't have folks that have historically only worked with adults now saying they can work with children. So that is a responsibility on the managed care plans. So we're going to go over these pretty quickly here, and then focus on the child welfare one in a little bit more detail. But the first one is individuals or children and youth and families experiencing homelessness. For children, youth, and families with members under 21, the criteria is broader. So it's folks experiencing homelessness, includes being unhoused, living in a shelter, losing housing in the next 30 days, exiting an institution to homelessness, which could mean exiting foster care, fleeing interpersonal violence, or sharing housing, which we sometimes call doubling up or couch surfing. And that's it for the child and youth and family age range and group. But for individuals, the bar is a little bit higher. So what I encourage is when you are working with a family or you're working with a child and youth, the best is to use the member that doesn't require additional criteria as it does on the adult side. Then the second population of focus is individuals at risk for avoidable hospital or emergency department utilization. This was previously called high utilizers. And this is really targeting folks that are using the emergency department as their primary care, or individuals with high needs based on their physical health or their behavioral health needs. And so what you'll see here is for the child and youth, the threshold is lower than for the adult population, and really the time window is also longer. So 3 or more ED visits in a 12-month period, or 2 or more unplanned hospital or short-term stays in a 12-month period for the child and youth population. Then the third population of focus targets the serious mental health or substance use disorder needs. Again, the criteria for the child and youth is lower than it is for the adults. So for a child or youth, they meet this population of focus based on their eligibility criteria for specialty mental health. And we know that our foster youth meet this criteria based on the fact that they are identified as a foster youth. So again, your individual may meet just clearly under this population of focus. And then we have individuals transitioning from incarceration Again, just focusing on the child and youth. The criteria is simpler here. The eligible group is children and youth under 21 or a former foster youth between 18 and 26 who are transitioning from a youth correctional facility or adult jail or prison who have transitioned within the past 12 months. No further criteria is required to qualify for this one. Then we have the two populations of focus that are only for children and youth. You cannot qualify an adult under this population of focus. So on the left, we have California Children's Services, or the whole child model population of focus. Here, they just, to qualify, they have to be enrolled in one of those programs and be experiencing at least one complex social factor influencing their health. So examples include lack of access to food, lack of stable housing, those kind of things. And then on the right, we have the child welfare population of focus, and this is the one that your individual and families would qualify under very easily. And so just to kind of walk through this. So first, it's a youth qualifies if they are under 21 and currently in foster care. And when we say foster care, we mean in out-of-home placement in California, or are under 21 and previously were in foster care in California or another state within the last 12 months. And then we have three subcategories under that. So A, they have aged out of foster care up to age 26, having been in foster care on their 18th birthday or later in California or another state. And then B, under 18 and eligible for or in California's adoption assistance program, or C, under 18 and currently or previously in California's family maintenance program within the last 12 months. And this includes voluntary or court-ordered family maintenance. And then I want to highlight this next slide. DHCS and CDSS together have built resources specifically for the child welfare population of focus. And so three things that we want to highlight here. First is that there are two ECM brochures, one written for child welfare and foster care staff, which includes, I believe it includes post aftercare as well, and one written for youth and caregivers. So these are useful both for your own reference and for sharing with the families that you work with. And then second, a self-paced online course called Enhanced Care Management Services for Child and Youth Involved in Child Welfare. It introduces an overview of California's child welfare system with an emphasis on delivering ECM for this population. And this is a great onboarding resource, and I've actually watched the entire series, and it's really good. It's easy to get through. A lot of additional great resources are part of that module, so highly recommend it to everyone. And then third, the Enhanced Care Management and Community Supports Referral Pathways website. This was created to streamline the referral process for ECM and community supports for Medi-Cal MCP members. And the link will be shared in a follow-up email, but the link on the slide when you get the PDF is clickable. I will share that it's a great website that CDSS and the team there have created, where if you know what plan your individual is on for Medi-Cal managed care, you click on that and then it gives you links to where their ECM referral forms are and where their community supports referral forms. The other thing I want to highlight here, and the positions that I mentioned before that the managed care plans have to offer, CDSS does keep those lists and they update them quarterly, and you can request those lists from CDSS directly, and the resource is on that website that CDSS created for CalAIM. All right, so the last population of focus is the birth equity, and the eligibility is for adults and youth who are pregnant or postpartum through a 12-month period and are subject to racial and ethnic disparities as defined by the California public health data on maternal morbidity and mortality. So, and in particular, this means our Black, American Indian, and Alaska Native and Pacific Islander pregnant and postpartum individuals. And this again goes back to the goal that I mentioned early on, that California is really trying to correct some inequities in health that exists with certain communities still. So we're going to talk about community supports. Just want to give a moment to see if there are any questions that are coming up about ECM. Please go ahead and ask them in the chat. We are going to go into more detail about how to apply this to the populations that you work with after we get through the next series of community supports. And Dr. Locke is going to go into a lot more detail about how it applies to your work. So let's go to community supports. This is the second pillar of CalAIM that matters for your work. And these are the state's attempt to really look at the whole person, not from a physical health and behavioral health, but also look at social determinants of health. And what I like to mention here is, you know, it's hard if you're worried about where you're going to sleep every night, or you're stressed out about other things, it's hard to pay attention to that physical health appointment in a couple of weeks. It's hard to pay attention to the behavioral health appointment if you're on survival mode day to day. And so, again, community supports is really looking at the social side of a person's well-being and how do we help improve that as well. So here's the architecture of community support. So community supports are services that MCPs can opt to provide in lieu of higher cost services that are traditionally covered by Medicaid. The core idea is that if California can pay for housing navigation today, it might prevent paying for an avoidable hospital stay tomorrow. So it's about upstream investment, downstream savings. The word optional is, oh gosh, my slide deck closed again. 1 second. I don't know why it keeps doing this. So one thing to bear in mind here with community supports is that they are optional, whereas for the plans to offer, whereas ECM is a mandatory benefit that they have to offer. And so what we have on the slide here, one of the links is CalAIM Community Supports Managed Care Plan Elections. You want to look at that every 6 months to see what is the latest offerings that the plans are offering in the counties that they have a presence. So each managed care plan gets to choose which community support to offer, and there are 15, and they get to choose 14 out of the 15. The 15th one is mandatory to be offered, and this is the last one that was approved by the feds and went live January 1st of this year, and that's transitional rent. But the other 14 are optional, and they get to choose which ones they want to offer. So I will say that the commercial plans like Kaiser, Anthem, and HealthNet are typically offering all 14 across the state. And then maybe in smaller counties and more rural counties where it's harder to find providers to offer these services, or they've assessed that there isn't a high need for a particular community support, they're not offering that particular community support. So it's good to stay on top of which ones are being offered, and the plans keep that up to date on their websites as well. So these are the community supports, and you'll see they're kind of lumped into 2 buckets here. Based on the policy, there are 2 policy guides. So volume 1 is a lot of services that will happen in the home. And some of these come with dollars attached to them as well. And so that's the significance of the dollar sign here. So just to call out a couple here, like asthma remediation, this will help pay for or reimburse for items that the member needs in order to keep their asthma under control. Then we have there's home modifications. If a person needs certain things to keep them at home, there is money attached there. And for asthma and home modifications, it's up to 7,500 lifetime benefit. It doesn't renew or, every year. It's a lifetime benefit. So up to 7,500. Then volume 2 is really targeting the housing focused services and some adjacent to that. And so you have housing transition navigation services, housing deposits, and housing tenancy and sustaining services. And this is what the state calls the housing trio. If you've ever worked in any housing program, there is a process to helping people get housing. First, you've got to find it through navigation. Then once you've done that, you've got to help them move in, which is the deposits, because we know moving into a new unit is costly. And so now we have money to do that and to help through Medi-Cal. And typically the plans are offering up to $5,000, which could include not only like security deposits and those kind of things, but also the items that they need to purchase in order to move in. So it could be kitchen items, bedroom items, those kind of things as well. It does not, however, cover first and last month's rent. And then we have the latest community support, number 15 on the slide here, transitional rent. The state recognized that previously none of the community supports actually covered the rent, and so they had put in an application to get that covered. And so that is a mandatory benefit as opposed to the others. That will pay up to 6 months of rent, but it comes with a lot of additional eligibility and authorization processes. And each plan is mandated to provide this service in every county it has a presence. It is mandated to work with its behavioral health department on this because it's tied to behavioral health dollars. And so we're not going to go into a lot of detail here today because it could take up another hour of training, but and it's rolling out kind of slowly in each county because it is really driven at the local level. But again, it is an option here for the individuals that you work with. This is another visual of the community supports broken up into 4 categories. And now I'm going to turn it back to Dr. Locke to talk about a couple of the community supports that we want to highlight for the populations that you work with.
So one of the community supports is actually called Caregiver Respite Services. And it's really designed to provide caregivers who require some intermittent temporary supervision, the ability to have respite in terms of that. It's provided on a short-term basis because of the absence or need for relief of these persons who normally care for and supervise them and are non-medical in nature. This service is distinct from medical respite and recuperative care because it really is only for the caregiver. One example is a resource family or an adoptive family requests short-term respite. Another one is medically tailored meals or medically supported foods, and it's designed to address an individual's chronic or other serious conditions that are nutrition sensitive, leading to improved health outcomes and reduced unnecessary costs. One example is a beneficiary who has type 1 or type 2 diabetes and needs a specific type of tailored meal. Medically tailored meals adhere to established evidence-based nutrition guidelines for specific nutrition-sensitive health conditions, and medically tailored groceries are pre-selected whole food items that adhere to these established evidence-based nutrition guidelines as well. personal care and homemaker services. It supplements the in-home supportive services. And if you look at the last few words, protective supervision for the mentally impaired, sometimes we hear adoptive parents, legal guardians, and others who have youth who are in, there are children who are in an SRTP and they're coming back, and they're really concerned as to, well, how am I going to take care of them when they come back? So imagine this particular option in which an aide is identified to help the resource family, the adoptive family, with the supervision of their youth for mental health issues because they have trauma triggers that lead them to leave the home in the middle of the night. So before we go to the next set of slides, are there any questions on the last few pieces we talked about, enhanced care management and community supports? All right.
Well, and I think we were going to take a break, but I was thinking I would take this opportunity to kind of there's been some rumors out there that CalAIM is going away at the end of the year. So I want to kind of level set some of that. CalAIM is not going away. What is happening is that the waiver that CalAIM has been under, the federal waiver, is ending at the end of this year. However, the benefits of ECM and community support don't need that waiver to continue. And they are part of what the state is requesting and requiring the managed care plans to offer as part of their contract with the state. And so there has been a lot of confusion out there in the community that, you know, why refer ECM and community supports is ending at the end of the year. And that's just not the case. They are here to stay. They are here to continue. Now, ECM again is a mandated benefit that the plans have to offer. Community supports are optional. And so what you may see is plans may decide to focus on community supports where there is a high utilization, and maybe they will start to not offer community supports that they don't see a lot of referrals or usage. And so that may change in the future. But again, CalAIM is here to stay. The waiver allowed the state to invest a lot of dollars into implementation to help providers, non-traditional providers like our social service CBOs that we typically work with, who don't typically come into this space, to come into this space as providers. And the state was able to utilize dollars to help with startup costs and implementation costs, because otherwise this is kind of unfunded costs on a CBO that generally is already kind of nickel and dime, right? And so those dollars are going to stop at the end of the year, because after 5 years of implementation, the state feels that it's been a success. And I would say I would agree with that statement. It has been a huge success. And so those dollars are not going to be part of CalAIM anymore. So again, if you're hearing that CalAIM is ending, that's not true. These benefits are continuing after this year. So you can make referrals. All right,
Thanks.
with that, oh,
Okay.
Go ahead, look.
Yes, thanks, Baljeet. So it is a good time to take our break. Let's come back at around 10:30 or so. And then what I'll do is I'll give a 2-minute warning, so to speak, before we come back so that you can transition back into this presentation. Feel free to pause your videos and audios. So let's talk about primary residence. Primary residence of a child in the context of a Medi-Cal managed care plan is the county where the parent resides. Primary residence for the child does not change if they go on vacation, if they go to a summer camp, even if they enroll in a college in another county. If the beneficiary moves to another county, they have 30 days to choose a Medi-Cal managed care plan unless there's only one managed care plan for that particular county. A primary care provider is the main healthcare clinician, usually a physician, for the beneficiary. They are part of the core health team and addresses a person's preventative and healthcare needs, including annual physical exams, arranging for vaccines, etc. And the primary care provider is also the point person that will refer a beneficiary to specialists and other types of care. A specialist is the clinician who has additional training and expertise. A pediatrician, for example, is a physician who specializes in the health of children. A child psychiatrist is a psychiatrist with experience in psychiatric issues among children. A licensed clinical social worker is a person who has a master's degree in social work and is a licensed mental health clinician. So consultation, referral, and transfer is pretty common in the healthcare field. A consultation is when one healthcare provider, let's say a primary care doctor, consults with another provider, like a child psychiatrist, and asks for advice. A referral is a request from one healthcare provider to another to manage one or more conditions, and that other provider is then responsible for leading all aspects of care for those conditions. For example, a primary care provider or doctor may not have enough expertise, so they will refer the psychiatric portions of that case to a child psychiatrist to manage. Sometimes you actually have a transfer of care. This is when one healthcare provider turns over all responsibility of comprehensive care for a child or a patient to another healthcare provider, either temporarily, like for example, a child is hospitalized, or permanently, such as when a beneficiary moves. The core health team includes a primary care provider as the lead healthcare clinician and include others as well, a nurse practitioner, a nurse, a pharmacist, a social worker, medical assistants, and sometimes a PCP, primary care provider, could refer a beneficiary to an additional specialist and have that specialist join the core health team. So in-network provider means a doctor or a healthcare provider that has been contracted or is contracted with a managed care provider to provide services at an agreed upon rates. Out-of-network provider means that doctor or healthcare provider does not have a contract with a managed care provider and will set their own rates. Outpatient services are usually those that a beneficiary receives outside of the hospital and does not require an overnight stay. So they can include things like an annual visit to your primary care provider, vaccines, lab tests, outpatient surgery. SRTPs and CTFs are residential facilities that provide outpatient specialty mental health services. It can also be an emergency room visit where a beneficiary might have to stay overnight, but the doctor hasn't admitted them yet into a hospital. Inpatient services are related to when a beneficiary has been formally admitted into a hospital or other inpatient facilities. And it usually includes healthcare staff, at a minimum a nurse, as part of the formal inpatient treatment plans and monitoring the beneficiary on site for 24 hours, 7 days a week, sometimes for weeks or months. PA, prior or pre-authorization. Some basic services, such as if you're going to your annual physical, getting vaccines, they don't require a prior or pre-authorization. However, there are other services like specialized services, specialty mental health services, medications that require prior authorization, as it gives the ability for the managed care plans to determine if those services are medically necessary. Timely access standards. This is the maximum time period in which a Medi-Cal or other beneficiary has to have access to contracted services once they are referred or an appointment has been requested. For example, for urgent care, they should get care within the 48 hours. For primary care, 10 business days, same with specialty mental health services. And for some psychiatric services, 15 business days. Network adequacy standards. This is the maximum distance or time, travel time availability of a service in relation to where the beneficiary lives. Primary care, hospital services, pharmacy, they have to be within 10 miles or within 30 minutes of a person's residence. Psychiatric or specialty mental health services can vary by county. It could be as little as 15 to 30 minutes or sometimes 60 to 90 minutes, depending on the county and how rural it is. One definition of continuity of care is the ability to stay with the same provider or get the same services at no additional costs or pre-authorization for a specified amount of time, regardless of where you move and have to change managed care plans. A beneficiary usually has to request that continuity of care and may get those services for up to 12 months if they move, including if they move to a county where there's only a single managed care plan. The other definition is a continuum of levels of healthcare for the beneficiary. This will involve either outpatient or inpatient services and would start with an initial visit with the beneficiary's primary care provider. So one way to look at it is you have outpatient services, intensive outpatient, partial hospital program, residential outpatient, residential inpatient, and hospital inpatient. And certainly it could go the other way as well. So outpatient may look like regular office visits with a mental health clinician. Intensive outpatient could be something like wraparound services. Partial hospital program could be something specific for mental health. There's also partial hospital programs for SUD, substance use disorders. Residential outpatient, like the SRTPs or the community treatment facilities. Residential inpatient, they don't exist yet in California, but it is coming. Psychiatric residential treatment facilities, and then hospital inpatient, things like acute psychiatric hospitals. So in the general community, oftentimes you skip steps, right? You have regular visits with a mental health clinician. They have a psychiatric emergency. They go straight to the hospital. Once they leave the hospital, one of the first recommendations is go back to your primary care provider. So they may have regular visits again with their mental health clinician once they're out of the hospital. For foster care, we sometimes see a foster youth or even an adoptive child or child who's in guardianship visit their clinician. You might have wraparound. You might end up in a SRTP or a CTF. They might have a psychiatric emergency. They transition back to a SRTP or a CTF and then transition back into the community. Transitional care services, we talked a lot about this, is making sure that when a beneficiary is admitted into the hospital or discharged from a hospital, there are coordinated services. It's available to all Medi-Cal managed care members. And while transitional care services actually existed before CalAIM, it wasn't as robust and it wasn't as coordinated as it is today. Patient or beneficiary-centered care was always a part of Medi-Cal managed care, but with CalAIM, it has a new emphasis or re-emphasis to a whole new level of services. And the planning and delivering and evaluating healthcare was based upon partnerships between the beneficiary and their family. And an important slide is the old question was, what is the matter with that beneficiary or patient? The new question that we ask nowadays is, what matters to the beneficiary or patient, right? How can we help the youth and their family with the youth's own personal healthcare journey? So there are parallels in the other systems, including child welfare. You know, a shout out to the CDSS technical assistance call teams, as one of the main questions is to re-ask a question that child welfare supervisors ask their social workers as part of that integrated core practice model. You know, what does the youth want? What is important to that youth? What matters to them? Right? You have risk stratification, segmentation, and tiering, which Baljeet had talked about earlier, but it's good to sort of reinforce this concept. It's differentiating members into subgroups based on their health needs, right? It has to occur every time a member is newly enrolled, annually after their enrollment, every time that there's a significant change in their health status, right? Those beneficiaries entering complex care or enhanced care management, they have to get another assessment. Child with or youth with special healthcare needs has to get another assessment, right? Currently in a acute hospital setting, they have to get an assessment. They were hospitalized in the last 90 days or 3 or more hospitalizations in the last 12 months. So another example in which they have to get another assessment. And then if there are 3 or more emergency room visits in the last 12 months, they have to get an assessment. And in the last 90 days, if they've been prescribed an antipsychotic medication or 15 or more medications, they have to be reassessed. So within the managed care plan, the expectation is that the primary care provider plays this key role in coordinating that care. In essence, continuity of care starts with the beneficiary's primary care doctor, regardless of what health insurance that a beneficiary has. Okay. Now, this is not an option. This is not a recommendation. And it's a newer emphasis. And when I say newer, it's just this past January, where the Department of Healthcare Services has said managed care plans must coordinate health and social services for children between different settings and different care. This means specialty mental health services, regional center services, education, social services. It doesn't mean that they subsume all those services. It just means that DHCS, the Department of Healthcare Services, recognizes that somebody has to help the families navigate through these different systems. So in terms of this, then, that entity that is in that best position for that continuity of care is the managed care plan, and the primary care provider or primary care doctor should be the lead. So population of focus, as Baljit had mentioned earlier, but the ones that are we often look at within the child welfare system and those who are adopted, individuals who are at risk for avoidable hospitalizations or emergency department utilization. If they have 2 or more hospital visits in the last 12 months or 3 emergency room visits in the last 12 months. If that child has been receiving specialty mental health services through a county mental health plan. If they are involved in the child welfare system in terms of this. And the most important aspects for all of these population of focus, just to reemphasize, is that they are automatically eligible, though not automatically enrolled. So it's one of these things where you'll have to work with your families to be able to look at that. Now, primary residency for a foster youth is before termination of parental rights is where the parents reside. After termination of parental rights, it's the county where the court terminated jurisdiction. So in essence, it's the county of jurisdiction. Okay. For the most part, primary residence for a foster youth, even if adoptive placement, and even if they're placed outside of the county, doesn't change. Under section 361.2, subsection E, it basically says that the court shall order care, custody, and control of a dependent child to be under the supervision of that social worker. And you have similar language under probation. And if they are placed by court order, the court may order that the social worker authorize medical, surgical, dental, or other remedial care for that child. And this also includes decisions for whether or not they should be enrolled in the Medi-Cal managed care plan. Okay, the similar language within the WIC code for probation. So if the child's in foster care, they shall not be required to enroll in a Medi-Cal managed care plan unless it's one of those 40 counties or so that only has one plan. And they may be voluntarily enrolled in consultation with the child and family team. But again, the decision is based on the county child welfare agency through that social worker. If the youth is placed outside of the county, again, there has to be a determination and consultation with the CFT whether or not to move or change plans. We would not recommend changing up plans unless there is some specific issue that relates to that. If they stay on the same plan, the Medi-Cal managed care plan shall process and appropriately pay out the claim. So for example, if they were in Shasta under partnership, they were placed in San Diego County in an STRTP, um, any of the claims should be submitted back to partnership. And if there is a change, every Medi-Cal applicant has to receive written notice of action at least 10 days before any action is taken that affects their Medi-Cal benefits. So this is important. If you plan to change something, you have to notify the beneficiary and their families 10 days before things happen. So all plan letter 24014 basically says that a foster youth can receive services from a previous provider for up to a year. Further, continuity of care requests can be made 60 days prior to the transition and processed within 5 calendar days of receipt with the following timelines: 30 days for non-urgent requests, 15 calendar days for those that need immediate attention. And then if it relates to affecting a child's, adversely affecting a child's health within 3 days. So it's best practice for the child welfare social worker to confirm that the youth, if developmentally appropriate, and the care provider are at the meeting with the ECM lead care manager to develop that ECM care management plan and to get a copy of that. And then to also make sure that the ECM lead care manager is a part of the youth core health team and invite them to the next and future CFT meetings if applicable. So you'll want to make sure that you can constantly identify who's on the core health team. If the child has special healthcare needs, it's actually recommended that consider asking the primary care provider to submit a referral to a specialist. So for example, if the child has mental health issues, you may want to refer to a child psychiatrist. If they are developmentally delayed or have autism, you may want to consider a referral to a developmental pediatrician to join that core health team. If a youth is hospitalized in a psychiatric or for other medical emergencies, you'll want to reach out to the ECM lead care manager to see if they will be the ones who are the transitional care services manager or if it is somebody else. You'll want to work with that person to get a copy of both the discharge plan and discharge plan evaluation. If the CFT, which should now include the ECM lead care manager, determines that either coming out of the hospital or determines for some other reason that a child needs an STRTP or CTF, determine whether or not the ECM lead care manager or someone else will take on that role of the transitional care services care manager to help with the transition of that youth into that STRTP or CTF. If the STRTP is in another county, remember continuity of care, foster care's primary residence, do not change the Medi-Cal managed care plans. However, do coordinate all parties to ensure that they are aware of what is going on. So for example, if they were in Sacramento and placed in San Diego County, and it would be hard to come back to Sacramento to see a primary care provider, and they find a new primary care provider, at least temporarily for the time that they're in the SRTP down there, that new primary care provider has to know to submit their claims back to partnership. And partnership has to know that there will be a provider from San Diego submitting those claims. We recommend that 6 months before jurisdiction terminates, whether or not they're being adopted or they're getting that guardianship, to schedule a jurisdiction termination continuity of care coordination meeting to not only include the child welfare representatives and the core health team, but the youth and their families, to make sure that everybody's on the same page. Make sure that the youth and their family understand who will be the primary care provider and health insurer. Explain to them that their current primary care provider has been and will continue to lead that continuity of care efforts with the ECM lead care manager as their primary point of contact after jurisdiction terminates. And if they decide to move to another county or even another state, explain to them that their current core health team can assist, including making sure that continuity of care forms are completed medical records are sent. So if they are going to another county, have that discussion, make sure that continuity of care is appropriate. They have the same level and access to the same level of services. The current core health team can assist with continuity of care forms and getting those medical records across. If they are planning to go to another state, each state has its own Medicaid plan. Just like California has Medi-Cal, other states have their own versions of Medicaid. And so they actually have to sign the youth up for health insurance in that other state as soon as possible. So the current core health team can make sure, again, that the medical records, continuity of care forms are sent to that other state's core health team. The point is, you'll want to encourage the caregivers to ask the questions now about getting more information about preparing for that transition. Now, once a youth has been given, or the caregiver has been given legal guardianship, or the youth has been adopted either soon after or years from now, remember that the adopted youth or legal guardian youth should be automatically eligible for ECM and community supports under other populations of focuses, right? So it's one of these particular aspects where Baljit had mentioned earlier, there's really no wrong door in terms of what it is. However, in order to get ECM or community supports, they have to be enrolled in Medi-Cal managed care plan. So the adoptive parents or legal guardian should reaffirm who is the youth's primary care provider and reaffirm whether or not they are on a Medi-Cal managed care plan. If the youth is on straight Medi-Cal, the adoptive parent should consider if there would be benefits in keeping them on straight Medi-Cal or to enroll them in Medi-Cal managed care, where they will then get access to ECM and community supports. If they are not yet in ECM, the caregiver should enroll them in ECM. Here is one of the websites that we wanted to share with you. And then per timely access standards, just remember that once the managed care plan determines that they are eligible for ECM, they have 10 business days to send it over to that ECM provider. And then that provider then has to assign a lead care manager. So the adoptive parent or legal guardian should also make sure that the ECM lead care manager is a part of the youth core health team and that their primary care provider is aware of the ECM lead care manager. The adoptive parents or legal guardians should also identify who's on their child's core health team. If, again, they have special healthcare needs, they should consider asking the primary care provider for a referral over to a specialist. If the youth is hospitalized, the adoptive parents or legal guardian should reach out to the ECM lead care manager to find out who will be their TCS care manager. And they should work with the TCS care manager to get a copy of both the discharge plan and discharge plan evaluation. If that STRTP is in another county, remember continuity of care and their youth's primary residence. Do not change the Medi-Cal managed care plan if at all possible. However, help the parents to understand, or the legal guardians to understand, to try to coordinate with everybody, especially if the youth is in another county, how to get those different services. You may have heard of the following variants, especially if, certainly in California, but sometimes outside of the state. You know, Medi-Cal is the payer of last resort, so any youth receiving AAP will not qualify. Medi-Cal managed care plans will not cover any services for youth on AAP. Or this third aspect where Medi-Cal will not cover an adopted youth who is in a SRTP that's being covered by AAP. So federal guidelines emphasize that inpatient and residential levels of care must not be the default treatment setting. In essence, there has to be a medically necessary reason for that. And the concept then is that they should be able to enroll them in EPSDT and receive any medically necessary treatment services and procedure, regardless of whether or not Medi-Cal covers it. And as such, if it is medically necessary, Medi-Cal will pay for it, including residential treatment for mental health services. Now, the nuance is that there's this aspect about what's called the legal liability of third parties, or what's called other health coverage. Think about it as like a deductible. You think about a deductible before the insurance pays for that, you have to pay for out of pocket. AAP is considered a type of other health coverage. So you have to utilize AAP first before you utilize Medi-Cal. And this is both at the federal level and the state level. The corollary to that is that they have to follow the rules of AAP. The rules of AAP are, technically speaking, right now, it's currently limited to 18 months and no more than the established rate of $17,616. So technically speaking, if the costs go beyond 18 months or if it's above 17,616, Medi-Cal would have to be utilized, but only if you can establish that it is medically necessary. This does not apply. The payer of last resort does not apply to services that aren't related to mental health services. So if there are other services that are normally covered by Medi-Cal, these include things like preventative health care, primary health care, physical health, dental health, applied behavioral analysis. None of these things fall under the payer of last resort in this particular case for an STRTP. The proposal is, just that, so you know, is to limit AAP for payments for 12 months, and that the tier rate structure, which will take effect in July 1 of 2027, will set the STRTP rate at $13,509. Okay, so per WIC 17121.5, any placements in out-of-state residential facilities must actually meet a qualified residential treatment program. In fact, all of our STRTPs in-state are QRTPs. For those adopted placements that occurred prior to June 30, 2025, they can continue for that 18 months with a 60-day extension and no more than the established current rate of $17,616. For those placements that occurred after June 30, 2025, the maximum time period now is 12 months with a 60-day extension. And again, any services that relate to mental health services, et cetera, would be covered by Medi-Cal or Medicaid in that other state and shouldn't be limited to or should not be affecting preventative care, primary health care, et cetera. If the adopted or legal guardian youth has fee-for-service provider and wants to keep that provider, when they change, they can do so. That provider has to agree to what's called an out-of-network contract with the Medi-Cal managed care plan, and they can continue for up to 12 months if the provisions are met. They have a current relationship with that provider. If the plan does not have a quality of care issues with that particular provider, if the provider will accept the plan's contracted rates or FFS, fee-for-service rates, and if the provider is a California state plan provider. If these requirements are met, the plan must allow the member to continue to see providers, including their current primary care physicians, surgeons, specialists, et cetera. There are a few things that it will not cover, including radiology, dialysis, and so on. And for adoptive children, don't replace the existing resources or services, including making sure that the family is actively working with post-adoption services staff. But you should now suggest to them that one of their other calls, in addition to PAS, post-adoption services, is to make sure that they contact their primary care doctor and core health team. If their child has private insurance, they can still qualify for Medi-Cal. Medi-Cal coverage can be added to an existing plan, and Medi-Cal will um, bill the private insurance first. Remember that concept of other health coverage. And then they'll pay for any sort of gaps. It triggers the formal concept of coordination of benefits in which services and funding are coordinated between two or more insurances. Okay, so what a person, an individual after adoptive placement or guardianship, they'll want to request enrollment in a Medi-Cal managed care plan. Once enrolled, they want to request that enrollment in ECM. They should qualify under one of the populations of focuses. And that, remember, the Medi-Cal managed care plan has 10 business days to then send it over to an ECM provider if they determine that the youth is eligible. And then you'll want to ask to meet with that or suggest to the parents or caregivers to meet with that ECM care manager as soon as possible. Then they'll want to request either ECM or community support and ask that ECM care manager to assist to confirm that the private insurance does not cover ECM supports. So, for example, they might have to notify the managed care plan claims department that the private health insurance does not cover ECM and community supports. More importantly, the primary care provider who accepts the child's private, who is currently on the child's private health insurance, they may have no idea what Medi-Cal managed care plan is, and that it's a secondary insurance, or that the youth has an ECM lead care manager. Okay, so as such, it's really important that the adoptive parents or legal guardians work closely with the ECM lead care manager, who should be able to help with that coordination. So here's information on how to sign up or enroll in that Medi-Cal managed care plan. Dr. David Satcher had a very elegant saying, risk factors are not predictive factors because of protective factors. And all of those in the room, whether or not they're working with foster parents, adoptive parents, legal guardians, et cetera, you all are a part of those potential protective factors. This includes maximizing CalAIM for foster youth, adoptive youth, and those in guardianship. And if the youth is healthy, keep them healthy. If the youth becomes sick, prevent them from getting worse and heal them as quickly as possible. And if the youth has serious, complex, or very high risk health issues, do everything possible to stabilize and maximize their health care, and do it in such a way that they can stay in the adoptive home or in the home of their legal guardians. If you were to approach this with your own child, how would you approach this? And it's really what matters to the foster youth, the adoptive youth, and those in guardianship, and how can we help those youth and their families and caregivers navigate the youth's own healthcare journey?
All right, thank you. Let me bring this down here. So we want to walk through how to make referrals to these CalAIM benefits of ECM and community supports. And the first thing is to think about finding out what Medi-Cal plan they have. So are they on fee for service? Do they have a share of cost, or are they enrolled in a managed care plan? Because remember, you have to be enrolled in a managed care plan to access the benefits of CalAIM. So that's the first step. And maybe if they're on fee for service, maybe having a conversation of how do we get them enrolled into a managed care plan. But if they are on a managed care plan and they're on full scope Medi-Cal, you can access the CalAIM benefits by calling a number that's typically on the back of their health plan card. And when you get onto Medi-Cal and you receive it through a managed care plan, you get a what they used to call a big card. And then you also then, once you enroll into the plan, get a card from the plan. And it's that card that you want to look at. You can also go online and access the referral form there for the member. The CDSS website that we've highlighted a couple of times today, they also have, if you know what the plan is, they have links directly to the ECM and community supports forms as well. And then you just complete the referral form. Now, I will share that the ECM referral form is anywhere between 6 to 13 pages long. And what I would recommend is, and a lot of it is just check boxes, and then it just explains when you check a population of focus, do you really understand what that population of focus is and what the definitions are, which we kind of covered earlier in the slides. So a lot of it, again, is just check boxes. There might also be information on the ECM referral form where it's asking you about other Medi-Cal programs that the member might be enrolled in. And this is because ECM, for some other Medi-Cal programs, the member cannot be enrolled in. For some programs, they can. And so the plan is responsible to make sure that if ECM is referred, that they're not already receiving a similar service and it's not a duplicative Medi-Cal service. So if you know the information, great. If you don't, just leave it blank. And again, it's on the plan to kind of figure this out. And then there might be like a comment section. One things that I really recommend to everybody is if there is an additional comment section, this is where you should lift up anything else that wasn't captured in the referral form. For example, if you want them to call you first before they reach out to your youth, child, or parent, you can put that in the additional comments. If you want to be part of any part of the process with the ECM lead care manager, that's where I would put that information. When you send the referral to the plan, like Block said earlier, they have so many days to accept that referral, make a determination, and then send it out to the appropriate ECM provider. And this is where it's really important that you check every population of focus that you think the member qualifies for, because you want a provider that has experience and expertise in multiple populations of focus. So, for example, if you have child welfare as a population of focus and the specialty serious mental illness as a population of focus, you want a provider that knows how to work with both of those populations of focus. So it's always a good idea to check off every one of those populations of focus that applies to the child or youth. Now, once you send it over to the managed care plan, they look at it, determine that they meet eligibility, authorize it, and then they send it over to an ECM provider that is in the county where that member lives. And hopefully in some of our much larger counties, it's in the community in that county that member lives. And then, that's when the ECM lead care manager starts the 7 core services, starting with outreach and engagement. The other thing that you can do is if you have an ECM provider that you feel is a good fit for this member, or maybe they're already working with the member in another capacity. Because what we have found is a lot of our CBOs that were maybe working in the wraparound space, or they're a foster family agency, they have come on to be ECM providers. And so they are actually encouraged to look at their current caseloads and to get authorization for ECM benefits for their current caseload. So you could directly refer a individual to an ECM provider, and then they work with the managed care plan to seek authorization. And they have what we call presumptive authorization, which allows them to engage with the member up to 30 days while they're also seeking authorization from the plan. So there is that option. The other thing is, you can go through the normal business timeline for referral and authorization, or you can request an expedited process, which typically then I think is a couple of days. And a lot of the referral forms have a check off of, is this expedited urgent? Just check that off. Because sometimes you're now in the throes of a crisis and you want someone to assist more fast than a regular process of the ECM. Now, for communities, so it's one ECM referral. And the other thing is, what if you thought they had Anthem and then turns out that they actually had HealthNet and you completed the ECM referral for Anthem? All of the plans will take anyone's ECM referral form. It's part of the no wrong door policy. And if you sent it to Anthem and they later find out that the member was HealthNet in some of these plans, they will send it over to the appropriate plan. The other thing is that there is a closed loop referral process as part of these referrals. And so it's really important that you put your email, your name, your number, all of that. There's a section for the referring party, because then the plans actually have to let you know what happened to that referral. Did the member engage? Did they decline? Was it denied? They need to let you know that. And the reason why we include that care management continuum as part of this training is that if they determine that the member doesn't qualify for ECM, then the conversation back should be, well, they need something. So what else do you have in your slew of services and part of the care management continuum that you can offer this member that I, as a professional, am saying they need assistance and help? So if it's not ECM, do we then stand up complex care management instead? And there are other benefits and services that they offer that we didn't kind of lean into today, but a denial for ECM should always be pushed back in regards to, well, they need something, so help me figure out what else do you offer, such as non-specialty mental health services. There's didactic services. Maybe a community health worker could step in if ECM isn't appropriate. There's so many other services that they can offer. Now, community supports works a little bit differently because the plans get to choose which ones they want to offer of the 14. And so you may have, some plans have a different referral form for each community support. Some have decided to capture all of them in one referral form. And we actually had a training, similar training as this one yesterday, and we looked at it and it was 27 pages long, which can feel overwhelming, but it gives you all the details of what the plan needs in order to process the community supports referral. Now, again, the CDSS website dedicated to CalAIM, if you know the plan, you click on that. It's like a plus sign, and then it has links to take you to the plan website where you can then complete the referral forms. What I always recommend, if you think your individual qualifies for ECM and you can qualify them under one or more population of focus, make that referral, because part of their 7 core services is to then assess, and it becomes part of their care plan for community supports, and to make those referrals to the appropriate community supports. And what we've learned is a lot of ECM providers have also come on to be community support providers because they some of them work hand in hand together, right? And so they can kind of process it all with the plan internally. And so we're not adding all these additional providers to a family. Maybe it's one agency that kind of does a slew of the CalAIM services. Any questions about the referral process? And if you're having issues, that's where bring in the child welfare liaison at the plan to say, hey, this is a youth that qualifies under the child welfare population. I need your help because I'm getting pushback on this referral. Now, I'm not going to go into this, but each slide, we've got a bunch of slides here. I can't take credit for creating these tables. I took them from a state agency that created this. And I want to say the source is there if you click it. This is the California Department of Corrections, I believe it was, CDCR, and they are heavily involved in one of the initiatives under CalAIM, which is the Justice Involved Initiative. We didn't spend a lot of time there, but basically that initiative is, or we didn't spend any time there. That initiative is really looking to offer pre-release services to individuals that are incarcerated, and then better warm handoffs when they get released, and the prison system is part of that. So the Department of Corrections created this on a web page, and I found it and I thought this is fabulous. So based on the county that you work in or your child or youth is in, look it up here, and then it tells you what the plan is, and I've added the links here as well. So that's the end of our presentation. You can definitely reach out to Locke or myself about anything about CalAIM. If you're looking for more detailed about case related, I would definitely go to Locke for that. If you're looking for the bigger picture on CalAIM, definitely come to me, or you can CC both of us on that email. We do want to open it up for questions at this point. And I did see one question in the chat that I don't know if we got to, and it said, could you provide insight on private duty nursing reimbursement for adoptive parents of children with complex care needs? I don't know if that's something you can handle, Locke.
Yeah. So there are at minimum 3 criteria for any. I'll answer it this way, and then I'll ask Josephine to come off mute if I didn't answer your question and whatnot. So any type of service, in order to be covered by Medi-Cal in one way, shape, or form, has to be medically necessary, has to be ordered or prescribed by a physician, any type of physician, whether or not it be the psychiatrist on the call, et cetera. And there has to be some form of pre-authorization that I mentioned earlier. If it fits those criteria, and the other aspect is that if it is embedded into, say, like a client treatment plan, then it can absolutely be potentially covered for reimbursement under Medi-Cal. Does that answer your question, Josephine? I wasn't sure if there was a different context in that, or you can write it in the chat if you want.
Yes, thank you so much. So this is also in this, because I'm also in the managed care space. I'm currently in operation for referral and things. But we've come in contact with certain requests that for parents that have really sick kids, but they're also providing foster care. So sometimes it seems like conflict that they're already being reimbursed for being foster parent. In addition to that, they're asking for anywhere from 12 to 24 hours of private duty nursing. And this is mostly for, again, kids that are really sick. So sometimes we identify that they may or may not meet criteria based on the presentation, the complexity of their need, but it's also with not having clear guidance of what we should be really doing as managed care plans.
Okay. So there is a little bit of difference between when we're trying to leverage sort of the 4E and AAP payments to cover for, because some, for example, some parents might say, yes, you pay for this, you pay for 20 hours of nursing, but I want 40 hours of nursing. And that's beyond the original scope, et cetera. So to be clear, one of the things that you'll want to, as part of the determination is, which child is this for specifically, and whether or not it's embedded within their care plan as to whether or not it's medically necessary. Okay, so does that make sense? So it is, the parents can say, well, they may have foster youth in the home as well as adoptive youth. And then they may say, well, I want this nurse to cover all of the youth. But in order to be either covered certainly by Medi-Cal and whatever aspect, each individual youth has to have a customized care plan, whether or not it be that care plan that through enhanced care management or their client treatment plan that has to then specifically say the nurse is specifically for this youth, specifically for X number of hours, and whatnot, if that makes sense.
Yes, thank you.
Okay. So the other question from Michelle is, can you provide more information about voluntary hospitalization and which can assist with the needs of the child? Okay, so voluntary hospitalization is actually not often used in child welfare, and it can actually be used in child welfare, but in the context of adoptive youth, et cetera, you want to look at Welfare and Institutions Code 6000 subsection A, subsection 2. Okay, so what it essentially means, and I can actually put it in the chat for you if you give me just a quick moment here. Sorry. So WIC. So the text of the code basically says parent, legal guardian, conservator, or whoever has care, custody, and control can voluntarily submit an application for that child. Okay. So the protection then is that regardless of whatever situation it is, it's a request for admission. It is not forcing a particular hospital to accept that admission, et cetera. And then the hospital will determine whether or not, one, it's medically necessary, and two, whether or not they have the bed capacity for that. For a child between, so there are a couple of things as well. For a child between 14 and 17 years of age in California, they have to also have an independent hearing officer determine whether or not they would meet the criteria for that. So one of the ways that I would suggest, if this was my child and I would want to get them admitted into a particular hospital, et cetera, is that I would meet with my child's current PCP as well as child psychiatrist. And we as a team would determine, yes, there would be benefits in getting the child a voluntary admission into a hospital. And what you would then want to do, or I would then want to say to the doctors, hey, doctors, could you help me pull together an admissions packet that includes the child's medical records? Okay. And then I would work with the hospital to then say, how would I get my child's private health information over to you in a secured manner, and things of this nature. You can actually Google something called the DHCS voluntary psychiatric inpatient voluntary admissions form, and the parent or caregiver would fill out that form. But again, it's one of these things where you'll want them to be ready with that information and whatnot. The other one you'll want to Google is, and I'll put it in the chat. DHCS. Is something called the Institute of Institute. So it's the Department of Healthcare Services has what's called an IMD list, an Institute of Mental Disease list. They update it quarterly. You want to go to the most current list, go to the fourth column and look for anything that is acronym of an AP for acute inpatient psychiatric program. It could be a hospital or something else. Okay. And between the form and between that list, a parent would usually contact the hospital that is or program, call them up first and basically say, hey, where can I send my application? Does that make sense, Michelle? Yeah. There's actually also what's called a U.S. Supreme Court hearing as well, in which for any child, it doesn't matter what age, that their concern was that so outside of child welfare, no child can walk into an inpatient psychiatric program and self-admit or request to be self-admitted. It has to be based on the consent of the parent. However, the U.S. Supreme Court was very concerned that a parent or even the state would admit the youth because they don't have the medical or clinical knowledge. So they basically said at the time of admission and on some regular basis after the admission, there has to be a physician who reviews the record to determine that there is still a medically necessary reason for that admission and that stay in the inpatient hospital. Okay. The other piece that I'll mention is that when you're talking about voluntary admission into a hospital, you're talking weeks, maybe a couple of months at best. Okay, very, very rarely does it go beyond there. So what I would also suggest is that the adoptive parent or legal guardian work with an STRTP that is willing to admit them after they step down from the hospital, but also willing to work with the hospital while they're in the hospital on a voluntary basis so that they're not surprised when the youth comes out. Does that make sense? So oftentimes even in child welfare, it's sort of this very linear process. They go to a psychiatric hospitalization, they come out, we try to find an STRTP, and then they get admitted to an SRTP and the SRTP hasn't worked with the hospital. And then within a few days, few weeks, they get discharged, given notice, right? But if you have the SRTP work while the child's in the hospital, including getting a copy of that discharge plan as well, with all the right information releases, et cetera, then at least the SRTP will know what had been the clinical plan and what are the recommendations of the hospital when they come out.
We do have one more question that just came in the chat. Are there additional resources available for MCP child welfare liaison to support cross-county transitions to avoid gap in care and fragmentation? One of the things that we've been kind of putting out there, and Dr. Locke can definitely add to this, is if there is a staffing or a CFT process that you're initiating, it's always good to have conversations there around if this is a planned move or a planned change. If you don't have the formal CFT process, maybe reaching out to the MCP child welfare liaison ahead of time to see what continuity of care they can initiate, what coordination they can initiate, especially if the child is going to transition to a new plan. Because everybody knows whose child welfare liaison is. This is not a hidden secret. The plans know who it is and they are used to working with one another. And so you could facilitate a staffing to kind of help do a good transition from one plan to another or from one county to another county. So that would be something I would suggest. Anything you want to add, Locke?
Yeah, and this is very close to you're familiar when you transfer, an adoptions case to another to a colleague. And one of the things you fill out is the standard cover sheet, right? Or a letter that says some basic information about the child. And then you sit down with the worker and have that warm handoff. You don't just transfer the case and things of this nature. So very similarly, if you know that the parent is going to change, what I would recommend to the parent or legal guardian is to reach out to their ECM care manager for their child, ask to meet with them, prep them, right? Hey, we're going to move from Sacramento to San Diego. Ask them specifically, I'd like a meeting with you so that I can know what the processes are. Formally ask them for a continuity of care form. It actually exists. I have the one from at least one of the plans. This is the one where what's the child's name? Who has been the child's doctor? What are the child's diagnoses? What are the medications? They're actually obligated to write that in terms of that. Get a copy of that and then talk before they even move. And then again, have that conversation with both the ECM person, talk to the primary care provider, and then reach out to the new potential provider as well, and basically say, hey, I'm going to be moving to your to your catchment area, whatever term you want to have the parents or legal guardians use, and I'd like to set up an appointment. It's very similar to all of us have some form of health insurance, I think, through our county employment. It's like when we move, right? How do we find, I have a 22-year-old now. How did I go every time that I move? How did my wife and I sort of think through the process of, hey, let's get our son a pediatrician at the time that he was pediatrician. Talk to him now. What type of doctor do you want? Are you comfortable with that? And then every MCP has a listing of providers and things of this nature. For continuity of care, you'll also want to consider, let's say that the child has asthma and the child currently has a pulmonologist that both the parent and caregiver really like, as well as the child, and they would want to have that year of continuity of care through telehealth. They can formally ask that of partnership, if that's the example. Does that make sense, or did that answer your question, Josephine?
Yeah, from MCP perspective, we do have the guidance from the state on how we manage continuity of care in general. However, the challenge that we have is that when we get requests either from the the county that they transition to, or from foster parents, is there seem to be a lot of confusion in what the process should be. So I guess our concern is that we want to provide the services. However, we also need, for example, if we're doing congenital care, we also need to have documentation of, again, who is the child's PCP, where have they been, where are they going, what care do they need. And oftentimes we don't have that. We have to piecemeal things together. We're going outside really of our responsibility to make sure that the child gets what they need. But um, I guess my other question is that is there any type of education that has been provided for this foster parents prior to the transition happening?
Well, that's why I recommend currently no in terms of the current process. One of the things we have certain laws and regulations, right? Like WIC 391 that basically says when you're working with a non-minded dependent before they leave the system, you have to sit down with them and talk with them over certain things. So one of the things that we do recommend as part of that training is a formal meeting with a potential adoptive parent or a potential legal guardian 6 months or within 6 months before they leave the child welfare system, to talk to them about some of these issues, right? To help them through that particular aspect. Now, if you're the AAP worker, you're dependent on the adoptions worker or whoever is handling the legal guardianship case to be able to do that. After finalization, as Baljeet had mentioned, there is an active effort right now for these Medi-Cal managed care plans to reach out to their potential beneficiaries. But as Baljeet also mentioned, they're looking to us, our help, because we're the ones who have that relationship with the parent. Does that make sense? So it is something that you can perhaps, again, reach out to through the ECM care manager, the child welfare liaison, et cetera, to be able to help, hey, this person is moving from one county to another, and could we get some help? I will say it's even difficult within, we've had a situation where it was a Kaiser Medi-Cal plan beneficiary. They ended up in a Kaiser ER, and there still was difficulty in communication. So it's not, and the other thing that I'll mention is that we had about more than 50 years, 55 years of working in the Medi-Cal managed care realm, but we've only had 3 to 4 years of CalAIM, especially around ECM and community supports. So it's a learning process for everybody. And the one last piece I'll also mention is any HMO, any Medi-Cal managed care plan works really well when the beneficiary is really well or is really sick. But in between, you have to be a very assertive caregiver or parent, right? They're not, it's one of these things where for a number of reasons, that's one of the drawbacks of any type of HMO, where you just have to be assertive. Now that you have the information, it is trying to help those parents sort of navigate through that system.
And I would add, Josephine, the situation that you presented is a really good example of a individual that should be referred to ECM, because the ECM lead care manager can act as a liaison back to the MCP and get some of this information that you're saying that you're struggling to obtain, because it's hindering meeting their medical needs or their physical health needs. And so that is one of the things that ECM can help with. Go ahead, Josephine.
Yes, we did identify that it's hindering their ability to continue care. So what we did in that situation was to actually assign a complex care case manager on our end as an MCP to help, coordinate everything until they're stabilized.
Right. And then, Michelle, you put in the link. Is there a video link that discusses ECM? I would say it is that module that I talked about earlier. It's one of the resources on the slide right after we discussed ECM for child welfare. There were, that's a CDSS slide. And so CDSS and DHCS worked with a vendor to create a training series to really understand how the ECM benefit works with the child welfare population, and that's open to anyone. So you don't have to be a professional to access that training series. And like I said, I've watched the whole thing and I found it to be very good for someone who's new to ECM and trying to understand how that benefit would work.
The other thing that I would recommend is that at the end of the slides, we had shown you earlier, Baljeet had gotten it from that State Department for each plan, the ECM link, the community supports link, et cetera. If you go onto those links, like if you went onto the Gold Coast or partnership link, they will have information, including some of them will have videos as well to talk about their plan in that context. The DHCS site sometimes talks about the general aspects, but then some of the particular sites have that information. And again, the other resource that I would really rely on is have the parent work with the ECM care manager. That's actually part of their role, right? They can ask the parent or guardian, can ask the ECM care manager, hey, where can I find out more information about benefits? And that is actually their formal role to be able to help with that family.
Right. And then we got another question. Jamie asked, just to clarify, for guardianship cases where the caregiver will receive KingGap or foster care funding, they only qualify for ECM for 12 months following termination of jurisdiction unless they qualify under other criteria. Yeah, and that's where it's important that you do you do look at all of the populations of focus. And remember, under the serious mental illness population of focus, our foster youth qualify under that because they qualify for specialty mental health services. And so you want to click all of the populations of focus that the member would qualify under. So I think for foster youth, it's appropriate to check the serious mental health and serious mental illness and the child welfare population of focus. Now what I don't know is for the reauthorization, if they ask additional information, typically the provider will work with the managed care plan to continue to provide the service. You typically won't need to resubmit a referral. It's usually the provider saying, we're still working through the care plan and they have not achieved all the goals. The member still wants to participate. Can I get reauthorization? So again, the provider typically does that.
And the other thing that I'll mention is that the populations of focus are the ones that are automatically eligible. Mm-hmm. So remember, I mentioned earlier that the managed care plans are supposed to, at the time of initial enrollment, every 12 months after initial enrollment, every time that there's a health issue, they have to do an assessment to determine whether or not an individual then is now eligible for either CCM or ECM. And once they are eligible under that category, then they're eligible for the next 12 months until it's redetermined, right? So for example, a youth has been adopted for 12 years now and doesn't necessarily qualify for any of the populations of focus, but they suddenly had some sort of mental health crises, et cetera. And you could ask the managed care plan, I'd like you to do that assessment to see whether or not my child would now qualify for either complex care management or ECM. And the moment that they, for example, complex care management is more transitory, right? Anytime that you have you're hospitalized temporarily, that's why the health system deals with that. And that's why they would work with transitional care services from the complex care management side. Does that make sense? So it's one of these things where don't worry so much about that they won't be automatically eligible. Just know that, or just try to make sure that the adoptive parent or legal guardian understands any adverse health issues or change in a person's health, they can go and ask for an additional assessment. Sometimes it's required by the MCP to do that assessment. Sometimes it's an ask from the beneficiary or the parents, and then they will go through the process. Yeah, this person now needs ECM, even though they didn't qualify for any of the populations of focuses.
Any other questions? I don't see any more in the chat, but always appreciate questions so that we can better understand kind of how this is landing on the ground floor. Peter just put the survey. We always appreciate folks completing the survey to share with us how the training landed, and then what are some other additional topics that you would like us to explore. I would like to take this moment just to share some of the great work that CFPIC and CWDA has been doing around the space of CalAIM. And so if you go to the CFPIC website, we do have a dedicated web page for CalAIM. And so you will see a lot of resources, prior webinars that we have done on this. And I believe you will now get a monthly newsletter of the continued work that we're going to do in this space. We hold monthly lunch and learns based on items that are seen as hot topics and relate to managed care plans and CalAIM. We also provide individual technical assistance if you need that. And I help coordinate that and then bring on other experts if necessary, like Dr. Locke and other consultants that we have working in this space. And it's an opportunity for us to support the work that you're doing with the children, youth, and families across the state.
And part of my role is that I am formally your technical expert consultant on individual cases, not especially for our youth who have very complex needs. And this also extends to not only county staff, but also to state adoption staff who I know have not only the adoptions role, but also in the roles of post-adoption services. Because the state has actually, Rebecca and her team, they've begun to set up the state TA calls on AAP more recently. I've begun to join that as well. But I also offer to you all, I do preparation calls to prepare for these cases ahead of time so that we can focus on some of the more technical pieces once we're in the call, and I can help prepare you for such a call.
Well, with that, we're going to go ahead and end our presentation. Really appreciate you all being here with us this Friday morning. Give you back some time, and maybe you can add it to your lunchtime. And really appreciate you being here, and have a great weekend. Thank you.